morning. I'm Dr. Marwa Meshaal. I'm an assistant professor of cardiology in Qasr Al Aini Hospital, Universities. Our talk today is about the rheumatic fever and infective endocarditis. It's an essential review, which I hope you find helpful. Rheumatic fever is an autoimmune disease and it's associated with group A beta hemolytic streptococcal infection, in the course of which there is carditis, arthritis, chorea, subcutaneous nodules, and erythema marginatum, which are considered as major criteria for the diagnosis. The diagnosis is based mainly on the modified Jones criteria. It has been developed in 1944, modified by the AHA in 1992, and a recent modification was added in 2015. The diagnostic modified criteria, the essential one: a major criteria, carditis, chorea, erythema marginatum, subcutaneous nodule. Minor criteria are hyperpyrexia, arthralgia, a laboratory finding of acute phase reaction, prolonged PR interval, and in the presence of evidence of preceding streptococcal infection. Now, according to the recent modification, the new guidelines applied by the AHA has introduced the concept of low, medium, and high-risk population. Children not clearly from a low-risk population are considered moderate to high risk. The low-risk population are those with acute rheumatic fever diagnosed in less than 2 per 100,000 school-aged children per year, or rheumatic heart disease as a total diagnosed in less than 1 per 1,000 patients per year. Now, these are the new differences introduced by the new guidelines, where you can find in the high-risk population, you can adopt the arthritis or the polyarthralgia or the monoarthritis as major criteria. And it's in the minor criteria, this is the modification of adding monoarthralgia to the group, and hyperpyrexia has been reduced to the fever of less than equal to or more than 38 degrees, ESR of more than or equal to 30 millimeter per hour. Primary prevention of the rheumatic fever is based mainly on the proper treatment of streptococcal infection. This is the very important step, and it's much way better than treating and dealing with rheumatic heart disease after it occurs. The secondary prevention is based on the long-term administration of penicillin-based drugs, mainly the long-acting intramuscular injection. Rheumatic fever with carditis and residual heart disease is treated for 10 years or till the age of 40, which is longer, and for some high-risk population, like those who are dealing with children in the nursery or in school, we continue the treatment as lifelong prophylaxis. For rheumatic fever with carditis but no residual heart disease, it's enough to treat the patient for 10 years or until the age of 21, which is longer. Now, as for the infective endocarditis. Diagnosing infective endocarditis is based on multiple steps of clinical evaluation, imaging, and laboratory techniques. As infective endocarditis is defined as infective inflammation of the endothelial lining of the endocardium of the heart, whether valvular or mural, infection of the endothelial lining of the great vessels, pulmonary or aorta, and infection of the intracardiac devices. These are the three categories of infective endocarditis. Now, we are classifying infective endocarditis as definite, possible, rejected, based on clinical and pathological criteria. Definite endocarditis is the diagnosis of infective endocarditis based on pathological evidence of infection of the examined cardiac lesion or distal embolization event, or the clinical diagnosis based on 2 major criteria, or 1 major plus 3 minor, or 5 minor criteria. The possible infective endocarditis is the diagnosis based on 1 major criteria and 1 minor criteria, or 3 minor criteria. As for the possible and definite, they are treated as same category regarding the investigation, regarding the management, and the line of treatment. Rejected infective endocarditis is when you can find an alternative firm diagnosis that can explain the syndrome of infective endocarditis, or if you have resolution of the infective endocarditis manifestation totally with antibiotic therapy, that lasts for 4 days or less, or if you examine the surgical sample and you cannot find any pathological evidence of infective endocarditis. Now, the diagnosis is 3 categories: possible, rejected, or definite, and it's based on clinical features, imaging techniques, and laboratory workup. This has to be done to confirm the diagnosis and rule out the multiple complications that are all systemic. According to the European guidelines published in 2015 to diagnose and manage infective endocarditis, you count as major criteria 1, blood culture positive for endocarditis. This is typical microorganisms when you have to isolate the organism from 2 separate blood samples, blood cultures, or microorganisms consistent with infective endocarditis, where you have to isolate the organism from persistently positive blood cultures. This is more than 2 samples or more blood cultures that are withdrawn with more than 12 hours apart, or single blood culture for Coxiella. As for the imaging, we count on the echo mainly as a cornerstone for the diagnosis of infective endocarditis. We have to check also for any abnormal activity around the site of prosthetic valve through the PET scan CT. This is a new introduced criteria introduced by the European Society in 2015, where you can detect activity around the valve, provided that the valve has been implanted for more than 3 months. Definite paravalvular leak or paravalvular extension of the infection as detected by cardiac CT. Minor criteria defined as predisposition, such as cardiac lesions, prosthetic, rheumatic, or congenital, cardiac devices, or intravenous drug abuse, fever of more than 38 degrees, vascular phenomena, including those detected by imaging only, and this was newly introduced by the European Society of Cardiology in 2015, immunological phenomena like glomerulonephritis, ocular nodules, Roth spots, or rheumatoid factor, and microbiological evidence. This is serological positive test for organisms that are known to cause infective endocarditis, or positive blood cultures that fail behind completing the criteria of major criteria. For the microbiological diagnosis and blood cultures, withdraw cultures before antibiotics. If possible, stop any antibiotics that has been used before for 3 days before the culture. And for the critically ill patient, you can withdraw 4 sets over 2 hours, then start your intravenous antibiotics. The routine serological testing for Brucella, Bartonella, Coxiella, and Galactomannan for Aspergillus has been adopted by Qasr Al-Aini Working Group, and it has been mentioned in the European Society of Cardiology guidelines, but if only you have negative blood cultures. As we have many cases with multiple causative organisms, we are now doing it routinely. It's withdrawn regularly with the blood culture. For blood culture negative infective endocarditis patients, the European Society has introduced the serological testing for Brucella, Bartonella, Coxiella, Treponema, Mycoplasma, and Legionella, and fungi like Aspergillus. Aspergillus infective endocarditis has been studied in a study that was published by Qasr Al-Aini Infective Endocarditis Working Group, where we used the routine serological testing for Aspergillus using the Galactomannan test. The cornerstone for the diagnosis of infective endocarditis, 2D transthoracic and transesophageal echo, are usually performed within the first 24 to 72 hours of admission. Three-dimensional transthoracic and transesophageal echo have been demonstrated advantages over the 2D echo. However, it's not yet adopted as routine examination. It's helpful to detect perivalvular extension, to detect perforation, to detect the size and the anatomy of paravalvular leak, particularly after the prosthetic valve implantation and prosthetic valve infective endocarditis. Yet, the conventional two-dimensional transthoracic and transesophageal echo will remain the cornerstone for the essential diagnosis, and it's difficult to replace. This is the algorithm how would we proceed with the imaging echocardiography for suspected infective endocarditis patient. If you have a suspected case and this is a prosthetic valve, you have to proceed immediately for the transesophageal. You don't count on the transthoracic image alone. If the transthoracic image is non-diagnostic and the echo images are not satisfactory and the clinical incidence of suspicion is high, you have to proceed for the transesophageal echocardiography. And for those who have positive transthoracic echocardiography, again, we proceed for transesophageal echo to confirm or rule out any perivalvular extension. And for those with negative transthoracic and satisfactory images for transthoracic echocardiography, if you have high clinical incidence of suspicion, proceed for the transesophageal. If it's low, you can stop, and if the symptoms persist, you can redo the echo again 7 to 10 days later. These are some images for the transthoracic and echo and transesophageal echo 3-dimensional, where in the picture of the left upper corner, there is suspected perforation that has been confirmed by the 3-dimensional echo. And for the picture on the right side, here you can diagnose with the help of the 3-dimensional echo valve body aneurysm or abscess. For that, the images on the left side and the lower corner, this is to detect the perivalvular complication of prosthetic valve, where you can find a paravalvular leakage. You can assess the size and the site and the severity, and it's better to be diagnosed and assessed by the 3-dimensional echo. What about the multi-slice CT cardiography? The key use of multi-slice CT cardiography in infective endocarditis is the non-invasive assessment of the coronaries, where it can be extremely helpful, particularly with the perivalvular extension and the presence of abscess, where you can delineate the relation between the abscess diagnosed by the echo and the origin and anatomy of the coronaries. It can be done that you can proceed for cerebral and abdominal CT if indicated during the same setting. Here is an echo picture of mitral valve ring abscess that's diagnosed and suspected by transthoracic echo, where you can find and see a flow of the mitral paravalvular abscess opening in the left atrium. This was a young lady, 24 years old, who had infective endocarditis, and she was on regular dialysis. This is the imaging multi-slice CT images of the same patient, where you can find here to the left side the standstill picture of the abscess protruding or originating from the mitral ring, and on the 3-dimensional reconstructed image on the right side, you can find the relation between the abscess and the coronary. It's away from the coronary, particularly the left circumflex. This was helpful for the surgeon. This is a 60-something lady with prosthetic valve aortic infective endocarditis. The lady presented with fever and heart failure within 2 months after her surgery. You can find a paravalvular leakage of the aorta, and there is an abnormal space between the aorta and the left atrium. In the multi-slice CT images of the patient, you can find multiple pseudoaneurysms originating from the aorta, and that the left main coronary is originating from one of these pseudoaneurysms. What about the PET scan, 5-fluorodeoxy PET scan? Few reports are existing. The technique is not yet a standard or a routine technique for the management of infective endocarditis patient, but it's very helpful that you can differentiate between the active infective endocarditis or healed old infections. For example, if you can find a perivalvular dead space that looks suspicious and you cannot guarantee if this is a mal technique or this is an old abscess that has healed, if there is no uptake in the PET scan, this can be helpful to rule out infective endocarditis. It's helpful too to detect activity around the valve that has been implanted after 3 months. This is abnormal. You should not find an activity around the valve that has been implanted after 3 months. If there is activity, this is a very highly suspicious finding of infective endocarditis. You can complete the diagnosis by adding one such minor criterion. And it's helpful to detect extracardiac spread and septic foci of the infective endocarditis, where you can explain the cause of persistent fever despite the appealing healing manifestation of cardiac infective endocarditis. Now, what about the non-cardiac imaging to complete the diagnosis and search for the systemic complication? First, we are going to talk about abdominal ultrasound and CT. Systemic embolization occurs in about 22 to 50% of infective endocarditis cases. The splenic embolizations are a major share. Splenic infarction is a common complication, and in about 5% of these patients, it can develop to splenic abscess. Also, we have manifestation of renal impairment, which is common. Acute renal failure is a common finding of infective endocarditis. It occurs in about 30% of the patients, either secondary to the immune complex of the disease, secondary to renal infarction and septic emboli to the kidney. Sometimes it's drug-induced. It can be very useful if you can do the imaging of the abdomen using the CT or the ultrasound, yet it's not standard protocol yet. These are some images of solid organ embolization where you can find renal infarctions, splenic infarctions, and to the left and the bottom, a huge splenic abscess. Again, some pictures of of renal embolizations. These are renal infarctions, and to the picture on the right and upper corner, the right kidney is almost non-visualized because of an embolization to the major artery. Mesenteric vascular occlusion also can be suspected when you find such multiple areas of air fluid levels. What about CNS imaging? CNS gets a major share of the embolization events of infective endocarditis. It's stated like 65% of the embolic event will occur to the brain. Most of them are asymptomatic, and unfortunately, many of them will symptomatize very late after it's critical or sometimes fatal, particularly the intracranial mycotic aneurysms which rupture. In one study, finding of the cerebral MRI-MRA upgraded the diagnosis of the infective endocarditis in 25% of the patients presenting initially with non-definite infective endocarditis, and it modified the management management plan in about 24%. Performed a study on 81 consecutive left-sided infective endocarditis patients who underwent brain CT angiography within 1 week. 34% had symptomatic CNS embolization, and the intracranial mycotic aneurysms that were asymptomatic were found in 15 patients, and the CT angiography changed the management plan in 21 patients, accounting for 25.6%. This is the published European study where they used the MRI-MRA, and this is Qasr Al-Aini where we used the routine cerebral CT angiography for the treatment decision management in infective endocarditis patients. This is one of our patients in Qasr Al-Aini. The patient was totally neurologically free. On the routine cerebral CT angiography, it was found that the right common carotid was embolized, and the right internal carotid was totally dependent on collateral circulation from the left side. Unfortunately, this side has a huge mycotic aneurysm. It was managed by embolization, and this is after the embolization of this huge mycotic aneurysm. This is his cerebral MRI after the embolization with histoacrylic to make sure that there is no large infarction surrounding which. How we are going to treat infective endocarditis? These are just general principles on the management and treatment of infective endocarditis. We use bactericidal and not bacteriostatic drugs, most of the cases, and mainly parenteral, not oral antibiotics. treatment is prolonged, and for prosthetic valve endocarditis, it should be longer than the native, where in infective endocarditis on prosthesis, we adopt at least 6 weeks. In native valve infective endocarditis, for sometimes, for uncomplicated cases, you can shorten the treatment to 2 weeks. In native valve infective endocarditis patients who are in need for valve replacement during the course of the infective endocarditis, the management and the plan continue as that for native valve infective endocarditis, not as for prosthetic valve endocarditis. In native valve and prosthetic valve infective endocarditis, day 0 or the duration of treatment is based on the first day, where blood cultures that was positive turns negative, or the clinical evidence of improvement of the case if the culture was essentially negative from the very start, or after surgery if the valve surgery came positive. These are the indications of cardiac surgery during the course of infective endocarditis as per guidelines of the European Society of Infective Endocarditis published 2015. Heart failure, it comes always as class 1 indication, either emergency if you are having hemodynamic instability, or urgent if the symptoms of heart failure are partially controlled by the medical treatment. Uncontrolled infection, class 1 or class 2A, if you are having local extension of the infection like intracardiac fistula or abscess despite being on proper medical treatment, or infection that's caused by organisms that are not responsive to the medical treatment, known to being non-responsive, like fungi and multi-drug resistant bacterial infection. Either for prevention of a recurrent embolic event if you are having persistent vegetation of more than 10 millimeter with embolic event despite it being on proper medical treatment and proper antibiotic therapy, aortic and mitral valve infective endocarditis with vegetation of more than 10 millimeter that's associated with mitral stenosis, aortic stenosis, or regurgitant lesions that are not yet indicating surgery, aortic or mitral valve vegetation that are larger than 30 millimeter, aortic or mitral valve vegetation that are larger than 15 millimeter, low risk patient, and no other indications for surgery. Thank you so much. This was our talk about the infective endocarditis and rheumatic heart disease in a rapid summary. Hope you find it useful.